Good evening. I'm Margaret Ann Bollmeyer. I'm the president of MCV Foundation, and I want to welcome you all here to our 6th Discovery Series event. We've done 6, this is our 7th. So we're so happy to see you here tonight. I would like to introduce a number of our Board of Trustees who are here tonight. Roger Beauvais, Charles Crone and his wife Jenny, Gail Johnson, our chair, and her husband Earl, Becky Perdue, somewhere in the room, back there, Joe Teefee, Harry Tallheimer, our chair-elect, and he's here, and Judy Woods, and Jim Starkey. Thank you. The MCV Foundation launched the Discovery Series in November 2013 as a way of helping to raise the visibility of VCU Medical Center and just the incredible work that's being done there and bringing that to the Williamsburg area. Earlier this month, MCV Foundation and VCU Health co-sponsored the Muscarelli Museum event, the Wine and Run for the Roses, and it was a great opportunity for us to become more a part of this community and get to know people here. I know that some of you were here. We're at that event, and we're looking forward to continuing our relationship with the Muscarelli. Tonight, as you know, the program is critical thinking about critical care, and we're here to learn about the amazing trauma center at VCU. We will very shortly meet our panelists, and at the conclusion of our panel discussion this evening, we will be having a strolling supper in the Osprey Room back behind this room. And before I get started, I do want to introduce as well the members of the Williamsburg Host Committee for the Discovery Series, because we have been able to do these events because of their support and their helping us connect in the community. Many of them are here tonight. I think Julie Baxter and Paul Dresser are on the committee who could not be here this evening, but Louise and Bob Canfield are here. Jenny and Charles Crone are here. Jane and Jim Kaplan are here, and Judy Forehand Woods. So thank you all for making this so possible. And at this time, I'd like to introduce Judy Woods to make a few comments for us. Come on.
Thank you, Margaret Ann. It's wonderful to see so many friends here. And on behalf of the host committee, I want to welcome all of you and thank you again for joining us. I did not know what video that Dean Strauss was going to show this evening. And I wrote my comments a week or so ago. And one of the things that at each of the Discovery Series that I have noticed is that at every one, there are members of this audience who will privately and publicly say they owe their life to what many of us will always call MCV. They owe their life or their good health to MCV. We have good hospitals here, but the difference is that VCU Health hospitals are teaching hospitals. The facilities are teaching facilities. And the second difference is the quality, the world-class physicians that you will see tonight, as well as their colleagues. In the current vernacular, that can be game-changing. In reality, that's life-changing. And we are so fortunate. Last November, we launched the Discovery Society. The Discovery Society recognizes individuals who contribute to the MCV Foundation in support of the VCU Medical Center and its units and programs, such as Massey Cancer Center, Pauley Heart Center, Neurosciences, Geriatrics, Psychiatry, Orthopedics, and others. Annual contributions from the Discovery Society members help sustain the clinical research efforts and enhance patient care access across the MCV campus. And 100% of those contributions go to the facility or specialty area chosen by Society members. Members of the Discovery Society share a commitment to supporting excellence in medical research and patient care and to raising awareness in Williamsburg and beyond of the amazing care that's available 52 miles from where we are. I'm delighted to report that we have 75 members in the Discovery Society. And their numbers continue to grow. Many of them are here this evening, and we thank you. They have been wonderful supporters of the Discovery Series and now supporters of the Discovery Society. Society members are given additional opportunities that we're not able to share through the Discovery Series. In March, we attended the opening of the new 640,000 square foot, $200 million Children's Pavilion on the MCV campus. It's one of the most advanced pediatric centers on the East Coast. We also attended and had a behind-the-scenes tour of the brand-new Richmond Neuroscience Orthopedic and Wellness Center. The Now Center is an amazing new concept in outpatient medicine. Plans are in the works for Discovery Society receptions in Williamsburg, and we hope to have ongoing seminars and updates from our wonderful VCU Health staff physicians. In all, we learn, we grow, and we have fun with the Discovery Society. As you're leaving this evening, you'll be given a folder of materials about tonight's program and the wonderful doctors that you will hear from. Also included will be a pamphlet about the Discovery Society. We hope you will look at it, read it, and consider joining us, again, to learn, to help grow our support of quality medical care, and to have fun. Thank you, and enjoy your evening.
So as I mentioned, we will be having a dinner after the program tonight where you'll have an opportunity to meet individually with the presenters here tonight and to talk to them about their presentation and to get to know them. So now I want to introduce someone who's been very important to the Discovery Series. So those of you who have been before know him, Dr. Jerry Strauss, who is the Dean of the School of Medicine at VCU. He has helped really put together these incredible presentations, and we are so grateful for what he's done for us. I want to say that many of you have had a chance to meet him and have already learned how much he's done for VCU and how important he is to the School of Medicine. He, some of you may not know, he has announced that he'll be retiring after 10 years of being dean. But he has promised to continue his role with the Discovery Series, so we're very excited about that. And I think that after all he's done for VCU, he is looking forward to getting back to doing some research, and we're happy about that as well. He'll be introducing our panelists tonight, so with that, I'll introduce Dr. Strauss.
Good evening, Williamsburg, and thank you for inviting us back. I can tell you this is one of the things that I look so forward to in my role as dean. And it's been 11 years, but and the fact that we are able to fill this room is very heartening. People are saying it's harder to get a ticket here than it is to get a ticket to Hamilton. And we don't have to do it to hip-hop, which is quite amazing. Tonight is a program that was actually suggested by the steering committee of the Discovery Series, and I was pleased to be able to accommodate their wishes. It's about critical care. And I can tell you that we have always promoted the VCU health system as a safety net health system that takes care of people who, in some cases, don't have other choices. But the safety net concept is not just taking care of those who are in need, who don't have the resources to seek medical care. It's also about caring for the critically ill. We are the safety net, providing the services that can't be provided in other hospitals, even though they're excellent facilities, because they lack the 24/7 on-call expert physician and nursing staff care. And you're going to hear a little bit about that tonight. Unfortunately, I couldn't bring the whole team. The gentleman who was featured in the video had a team that would have filled this stage and more. As a matter of fact, I think we probably have a picture of it because we celebrated them at the Trauma Gala, the Shining Night Trauma Gala, a year ago. And you would be amazed at the number of people who touch a single individual who's had such a traumatic injury. Works in clockwork. And I hope you get a chance to sense some of this. And that's true whether it's an event that involves a single person, a heart attack, a stroke, or an accident like you just saw. Multiple casualties in an explosion, in a vehicular event, in an industrial event. Same type of teamwork. And also events that occur outside of the United States that potentially bring risk to our population. Ebola. We have to be prepared for all of that. And we do that with regional excellence, national trend-setting concepts of care, and trauma is all about a system of care, not just a single physician, and I hope you'll get a chance to hear about that too from my colleagues. But we also work hard internationally to spread the knowledge that we have gained in terms of critical care to parts of the world that need it most. And two of my colleagues who will be with us this evening are world-renowned for the work that they've done in the developing world, building the trauma services that will basically save lives and give increased quality of lives to people in Central America, Latin America, Africa. And this is done with great compassion while they're continuing to do their day job in Richmond. They also work ceaselessly to promote injury prevention through trauma education, a preventative strategy which many institutions have yet to adopt, but it's terribly important in terms of reducing the burden of critical care. So let me introduce you to our distinguished faculty, and I'll do it in alphabetical order. Please come up and join me on the stage. Dr. Michael Aboutanos, who's Professor of Surgery and Chief of Acute Care Surgery Services in the Department of Surgery. Dr. Michael Feldman, who's Assistant Professor and Medical Director of the Evan-Haynes Burn Center, and you'll learn about this wonderful facility from him. Dr. Sudha Jayaraman, Assistant Professor in the Department of Surgery and also one of our distinguished trauma surgeons. Robin Manke, Director of Emergency Management in the VCU Trauma Center. She's the secret sauce that sets up our trauma care system. And someone that you've met before in previous Discovery series, Dr. Joseph Ornato, Professor and Chairman of the Department of Emergency Medicine. So I'm going to start off with Michael Aboutanos and ask him a very simple question because there is information that you need to know about the tiering of trauma centers. And VCU is the only level 1 trauma center in Central Virginia. And I'd like Michael to give you a nutshell a presentation on just what a level 1 trauma center is and how you achieve this designation.
Sure. So first of all, thank you. It's an incredible honor to be here. I really appreciate all your time and this amazing opportunity just to hear what we do, and what I think is really for you, for our own families, our own region. I feel that I am absolutely blessed to be at MCV. I also call it MCV because I was trained in MCV, but also VCU. and also to be initially part of the trauma center and now chief of acute care surgery in the trauma center there. So what does it mean to be a level 1 trauma center? And this is incredibly important. It is the state designate centers based on level 1, level 2, level 3, and that depends on the amount of resources, the commitment, the quality improvement, the programs, and the ability to provide the highest level of care at any time, 24/7. And that designation really depends on having a voluntary presentation and opening your door for the state to come and evaluate you to see, do you really have these resources at any time? At the same time, beside being a state-designated level 1 trauma center, we're also American College of Surgery verified. That's basically a nationally verified trauma center. So they come in, they're verified. You really have the resources to take care of anybody and to provide the optimal and the best level of care at any time. And can you put together the team that can respond within minutes to any type of injury that require any kind of level of care put together? Only when you could do that, and we go through rigorous evaluation, can you be designated a level 1 trauma center. Does it make a difference? Absolutely. So there's a significant difference not only in mortality, but also in the type of morbidity and the ability to put someone back to society, back to their family, to their loved ones. Our enemy is time. We work against time, and you have to be the best of the best. And we have the largest trauma center in the country. We're the best at it. We're proud of what we're doing, and it is a place that I want to bring literally my family, my son, my daughter. And so to be at that level, you have to have the best team available to do this, and you have to have 100% commitment from administration, from the hospitals, and from the School of Medicine, from everyone to provide these resources. So I think that's one major part of providing the optimal care and the best of care. The other part that, if you allow me, I don't want to take too much time. I know you said quick, but if you allow me.
Sound bites.
Sound bites. Sorry. The other part, people don't realize that to be a level 1 trauma center, you have to provide the resources all the way from injury prevention to rehabilitation. You have to provide all that. We're just as much involved in preventing the very injuries that we treat and we have one of the best programs in the country for that. Another part of the level 1 trauma center is that our role is in entire Central Virginia to be in charge of the entire system of where patients go, where's the best place for them to go, and to direct the education across the entire region, all the way from the pre-hospital providers to the nurses, to the social, anybody who's involved with injury. So that's one major part where a level 1 trauma center has a regional responsibility. And VCU, we are very special in the sense that not only are we comprehensive adult, we're also comprehensive pediatric and comprehensive burn centers all together. And that combination does not exist anywhere else in the Commonwealth. I'll stop there before I could keep on going. But
Thank you, Michael. Well, as much as we would like to be the Maytag Repair people and sit in our offices and not have to deal with the types of events that you saw in the video, we can't. There are about 4,000 to 5,000, close to 5,000 trauma admissions, 5,000 a year through Michael's service. And they need to be there 24/7, whether they're the Maytag Repair people who don't see anybody, or whether they're there to see mass casualties. So that incredible cost, because as I said, this is a team, and it's a team that's much larger than what you see on the stage. So let me turn to Robin, because you're part of our system of care. You and Joe, because you guys work together, because a lot goes on before a patient actually comes through the doors of our emergency room. There's a lot of pre-hospital care that gets the team ready. And the coordination of this for individual events or events that involve multiple people, Robin's the key. So,
I guess I'm the key.
you are the key.
I
So
have
why don't you explain your role?
my role. I have the best job at VCU Health, I can tell you, even better than these guys. I get to plan all those disasters, emergency preparedness events that might force many individuals to show up at our emergency department door. And I have to take all of those little pieces of each of these departments and make sure that they're trained, they know how to respond. Should it be a chemical trauma, a radiation trauma, any of those trauma events that may encourage mass casualty incidents, that each of those individuals that have to respond first know or understand their role. If we think back to the UCI bike race in September, we had to make sure that not only we were protecting our critical infrastructure that sat right on the race course of VCU MCV Health, to make sure that our staff were taken care of, making sure that if something bad, such as a Boston bombing or something, that we had the things in place to be able to take care of our staff, our patients that were already in-house, and also those who were injured. We also had to take care of our staff that were down 10 blocks from us in a tent, taking care of those athletes, taking care of weather-related events, the tornadoes that came through Tappahannock recently. As a medical control or taking care for the region, we have to institute and look at all of those EMS agencies and where those individuals are going to be taken. And as a Level 1 Trauma Center, we decide and determine, along with EMS, where those individuals are going. So emergency management spans all the way from a mass casualty incident to setting up an Ebola treatment unit, because we know how to do it best in Central Virginia and in Virginia. So it spans every spectrum of critical care.
Joe, why don't you comment about the importance of our relationship with the emergency medical services, and how you personally have been involved in mass casualty triage?
Sure. As Dr. Strauss mentioned, I chair the Department of Emergency Medicine. We're a huge department. We're blessed to have been recently doubled in size and renovated, so that we're about 100 beds, taking care of about 100,000 patients per year. We're clearly the largest in the state. Myself personally, I've been the medical director, continue to be the medical director for EMS in Richmond, Henrico County, and several physician members of my staff are medical directors for the surrounding regions, as well as the aeromedical services. What Dr. Strauss is referring to is sometimes in life unexpected things happen. On September 10th, 2001, I flew commercial from Richmond to New York City to chair a National Institutes of Health research meeting for what's called a public access defibrillation trial. We had 23 major cities involved in that trial, and we were the ones that showed that laypersons could save lives with automated defibrillators in public places. And we had every 6 months an investigator meeting. It was our turn to meet in New York City, and it happened to be on September 10th. We were stationed for the meeting across the Hudson River at the Brooklyn Marriott. And the long story short is, of course, the next day was that horribly tragic day in which the Pentagon and World Trade Center were attacked. We actually witnessed the building collapse, and within a very short period of time, New York City resources were marshaling from every direction to try to get as many folks to the Twin Towers as possible. And an announcement came on one of the TV sets that was in the lobby of the hotel that basically said any emergency medical trained personnel that can get free, please identify yourselves. The two major trauma centers were getting really inundated with casualties. This was actually before the two towers came down. With me were 31 other emergency medical services directors. All of us run the major cities, EMS systems in New York, Chicago, LA, et cetera. So I was actually the leader of the team because years before I had run one of the EMS systems in New York City and had worked with New York Fire. Long and short of it was I sent one of my team members, they flagged down a responding vehicle, and next thing we knew, New York City Fire and Police commandeered a city bus, and as tens of thousands of people were evacuating lower Manhattan, the 32 of us found ourselves on a bus with a police escort in front and behind us, being brought to what is now called Ground Zero. And for the next approximately 12 hours, our team was one of the 2 triage centers for World Trade Center for that horrible day. Could tell you lots and lots of details about what occurred during those 12 hours. But the interesting thing was that all the cell towers were out. We had literally no communication. The only comm I had that day was a fire radio at the front of the command center. And we didn't even learn that the Pentagon had been hit until about 5 o'clock in the afternoon, as hard as that might be to believe, because we were really isolated and focused on what we were doing. We set up a 32-bed field hospital in front of the Solomon Smith Barney building, which is about 5 blocks directly up from Ground Zero. Firefighters from New York City Fire, we sent them into the building. They pulled down 32 tables and easels. We asked them to pull some easels down. We spiked IV bags, put them on the easels. And the interesting thing was the other triage center was set up on the opposite side, actually at Chelsea Piers at the tip of Manhattan. And we didn't really know who was there. I met them several months later when we gave some national presentations on what happened. And New York City Fire took thousands of photographs. We have presentations on all of this. And the interesting thing was our colleagues, probably a mile away, were doing almost the same thing that we were. It was all the training that we had that really kicked in as to how you set up a mass casualty field hospital, really with very little to work with initially. Within an hour or two, of course, New York City Fire brought us lots and lots of resources. So it was a very interesting experience. The hardest thing was to come to grips with it. During the 12 hours, we were all just, on adrenaline and doing our jobs. But, in the days after that, it was really kind of difficult, especially getting back home, getting interviewed by the media. It's like, well, everyone would ask, well, what was it like to be there? And of course, you could answer in terms of what happened. But the hardest thing was trying to know the right answer because, were we lucky to be there? No, we weren't lucky. Nobody was lucky on that day. Were we unlucky to be there? Well, we were there doing our best to help as many as we could, and we did. And finally, we settled on, all of us, the right word we thought was we were privileged to be there, to be able to serve. And that's pretty much.
Thank you, Joe. Powerful story, but the people sitting around me have lived through some very powerful stories, like the one video that you saw, Paula Ferrata, one of our trauma surgeons, Sudha's colleague, the emotional toll on people who deal with these critical life, critical conditions is truly amazing. And the resilience that is needed to be able to do this day after day is something that shouldn't be forgotten. So I'm going to come back to Sudha because I've got an important question to ask her, but I do want to talk to Michel about the Burn Center, the Evan-Haynes Burn Center, which is also an incredibly unique resource at VCU, the first civilian burn center in the country. So, Michel, give me a little bit of a summary of what you do on a daily basis.
It's complicated. And I wish that, like what Dr. Aboutanos was saying, that you have to understand that this really isn't about just us up here. It's about this whole infrastructure and the support that the hospital has, so we can take care of some of the most complicated patients that you'll see. People who are in a plane crash, people who are in explosions, people who have chemical burns, lightning strike. All of these patients require very, very specialized care from the minute they come in the door, where our trauma surgeons are stabilizing them, to where we're doing our burn care, resuscitation, dealing with wounds, dealing with pain, for children, trying to treat their anxiety and make sure that they are comfortable, that their parents are treated as well. All of that's on a daily basis. And really what I want you guys to understand is it's not just one particular person, it's a whole family. And I would love to introduce you guys to the Byrne family. If you're ever in Richmond and you happen to have an injury of that nature, please come see us. You'll be treated like family as well. And what we have is this rich history. The first civilian burn center in the United States is pretty amazing. About a month before, Brooke Army opened their doors. So before that, there really was no unified care for burn patients. You were just kind of mixed in with everybody else. They didn't even know that burn patients needed fluids. And Dr. Evans was the first to put out a resuscitation formula for that. And then he unfortunately died at a very young age, and Dr. Evan-Haynes Jr. took over and was there for 36 years. His son actually runs pediatric surgery at VCU still, so the history of some great physicians continues. So daily, really, it's to make sure that we give the best care possible and try and get the best outcomes possible.
Most people don't realize the important functions of the skin. Mike's a plastic surgeon. You wouldn't believe that plastic surgeons do these things. Seriously, and I hope this gives you profound new respect for people who work on skin. But the barrier function of skin, not only letting things in or preventing things from getting in, but also preventing things from getting out, like fluids, absolutely important. And dealing with patients who have burns over 70% of their body, that's life-threatening. And you're thinking about how do you restore that barrier function? How do you prevent infection? How do you keep fluid balance intact? I mean, these are incredible human physiology experiments that make all the difference in terms of survival and quality of life. And Michael's got the team.
I wouldn't use the word experiment too much. Sorry.
Yeah.
We base our care off of evidence-based medicine. We are not just focused on making sure that you survive, making sure that you look as good as you can, that you function as good as you can. I mean, it's one thing to survive, it's another to have quality of life, and I think that's hugely important.
Sudha has been one of the leaders in the thinking about trauma care in the developing world, and she's had experiences in Rwanda, now working with Michael Aboutanos with the Pan American Trauma Society, and I'd like to ask her to say a few words about the global burden of trauma and then what we can do as a developed world with a trauma system that is well-oiled, how we can benefit these countries that desperately need this type of medicine and technology.
The big thing about trauma is that it's really a neglected problem worldwide. You don't think about trauma when you think of the rest of the world. You think about Ebola, you think about HIV and malaria. And yet, trauma is actually one of the biggest problems worldwide. It actually is larger than all of those preceding problems I mentioned combined. But how much of that do you hear about in the news? You hear about it when there's an earthquake in Haiti, or there's a tsunami in Japan, or there's a war. and it's a very reactionary situation. Well, because of the systems that we have in place, our system is not very reactionary at all. We're prepared. Dr. Ornato's Richmond Ambulance Authority can tell who's going to need an ambulance in 5 minutes and where. And that's a very different environment that we're privileged to be in, but that's not the case in the majority of the rest of the world. And one part of what we do is work with other colleagues, other surgeons, emergency medical specialists, other ambulance staff in various countries to help them figure out how to develop the resources they need in their settings. Their needs obviously may be different, their resources may be different, so we need to be thinking a little bit differently in each of their settings. It's like if I visit any of your homes, your refrigerator has different things in it compared to your neighbors. And so you have to think about what each setting needs. I've been fortunate to be working in East Africa over the last 8-9 years in Uganda and Rwanda. Rwanda, as you know, went through the genocide in the 80s and now is a flourishing country. And there's almost on a yearly basis, there's an article in The Economist or the Wall Street Journal talking about how it is really transforming into a very successful country on the continent and is really trying to become what they call the Singapore of Africa, and is trying to be the main country where people go for healthcare, partly because it has no natural resources. So there isn't any coal or gold or any sort of ability for the country to have any economic development, except for its people. So they're investing heavily on the ability of their staff to be able to do anything and be the resource for anyone from around the continent. So I've been privileged to be working with the only teaching institution in the country, the only institution that has a surgery training program and an anesthesia training program. They train roughly, I think, 3 surgeons per year for the country of 10 million people. So you can imagine it's a bit of a problem. I think now they're up to about 50 surgeons for the country. So those settings are critically short-staffed. And it's important when you're short-staffed to be efficient with your resources. You don't have time and resources to waste. And so they were very interested in seeking a partnership with me and some of my colleagues. I did my fellowship at Brigham and Women's Hospital at Harvard Medical School, and we had an active partnership through Paul Farmer and Partners in Health in Rwanda. And we've been working with them over the last several years on how to develop trauma system within the capital city. And a lot of that is looking at pre-hospital care in the ambulance system. They don't have paramedics, they don't have EMTs, they have nurses, they have midwives, and they have nurse anesthetists who ride the ambulance. We're trying to figure out who they care for, what care they provide, what quality measure should we even follow, what should we expect to say that they're doing a good job or not. How do we engage them when they don't have any significant training to be able to provide the most basic of medical care. So that's what I've been involved in.
Michael, would you add on?
One thing I would add is, which is very important, and I recruited sort of heavily because of this interest. I think what we do at MCV is 100% underestimated. People have no idea what really we do on a daily basis and how effective it is and what's our regional level. So I've always thought that we can have a global impact if we can teach others what we're doing here, right here, in Virginia, here, in the Central Virginia. And we could take all this aspect and we could have this incredible amount of people, of resources, and of systems, and say, our impact is really global. So you have to put together the right team, and we've done that. We learned a lot from the pre-hospital, from the hospital, from the injury prevention, from rehab, everything that we do for one person here. So people say, think globally and act locally. The way our model is really think locally, act locally. Think globally, act globally. And so this is kind of what we have done, and we have actually taken a lot of what we've learned, and we went to different parts of the world. We went down actually to Latin America, and that's another part that we went down. And Dean Strauss was very, very instrumental in helping us push this vision. And we started presenting what we're doing in the field to a lot of people, teaching them how to help themselves, and saying, this is how we're doing in Richmond. This is how we're doing for the entire system. But now you have to adapt it to your own levels, based on your resources, and we'll work with you with this. And by no time, we became what we call the headquarters for the Pan American Trauma Society, which is the leading society all the way from Canada to Argentina that takes care of how trauma systems should be developed. There's 18 other societies and countries under us, and people have no idea this is what MCV is doing, it's what VCU is doing. And so everything that we do here has a significant global impact. We created international program, people coming and visiting us, trying to figure out what can we learn from you guys, what can we do. This is part of our agenda, is of saying this is, our world is small. It's not that big anymore. And so we cannot hide anymore. They say if you're a gem on a hill, you'll shine. And this is kind of what we're doing. And I am, like I said before, incredibly grateful and blessed to be in this type of a hospital, of a system that is able to think at this level, able to say, yeah, we understand, even though we want you here, we want you to take care of the people here. If you can influence somewhere else, we're going to back you up. And I've had people come and say, well, and I've asked Dean Strauss, I said, why would you support this system? Why would you support us doing this? And basically his response is that our mission is much bigger. Our view is much bigger of who we are. It's incredible what we're doing. And the number of people now that are visiting us, what we're able to attract from all over the world, people who want to come work with us here. So we're benefiting locally from this international system as well. And so it is, not only are we the only level 1 trauma center and the only one, burn center in the region and the only pediatric trauma center in the region, every one of what we're doing and every people who are on our staff are major players at the global scene, part of the Pan American program and the entire international global program that we're doing. And I'm really grateful that Dean Strauss was able to say, let me show everything, all the way from the pre-hospital to the disaster preparedness and what we're doing, all the way to the EMS aspect, to the burn. These are huge things that we've been doing them for the past 30 or 40 years, and now we're finally having the ability to really impact many, many, many people. And so I think the world that Dr. Ornato said is extremely important. We are very privileged. I think I'm just privileged to be here and have you guys listen to what we're saying.
And what Michael and his colleagues up here are doing is teaching physicians, nurses, support staff the state of the art in trauma and critical care. But that's not enough for us. We also have a very significant investment in research that will push the frontiers forward, both in technology as well as medical and surgical care. And Joe Ornato was instrumental in bringing the premier critical care research institute to VCU, the Weil Institute. And it's named after Dr. Hal Weil, who was the founder of critical care medicine. Is that a fair assessment, Joe?
That's absolutely correct.
And the institute that was started by him and his family was looking for a new home, a place where its research program could flourish and be translated into clinical care. And Joe, why don't you tell the story? Because it's amazing.
Yeah, Dr. Weil was really truly one of our heroes and giants in the field of resuscitation and critical care. As Dr. Strauss mentioned, he actually founded critical care and the Critical Care Medicine Society that still bears his name today. he was at the University of Chicago through the last part of his academic career in the 1980s, and decided it was he and his wife that it was time to retire. He'd always wanted to retire to the Palm Desert region of Southern California. And his retirement didn't last very long because at his retirement party, many of his grateful friends and patients got together and they said, you know, Dr. Weil, it would really be a shame for your work not to continue. What do you think if we raised some money and built you a research institute in Southern California? And that's exactly what they did, but it was quite an institute. They built him a $20 million building. And it has, since the early 1990s, it has been, as Dr. Strauss mentioned, the premier resuscitation laboratory in the world. Since then, they have published over 2,000 scientific papers. They have trained over 400 international fellows, and they virtually dominate the American Heart Meeting agenda and scientific presentations every year in November, which is the largest resuscitation meeting in the world. In 2011, sadly, Dr. Weil, in his late 80s, passed away. Really sad moment, you know, for all of us who were privileged to be his friend and colleague. However, his work and legacy has gone on, but the Board of External Advisors realized that with the loss of really the brilliant clinical and research mind of Dr. Weil, that they really would be wise to look for an academic medical center partner that could essentially be their new home. They were very careful to really check out a number of places that were very interested in having them move there, University of Minnesota, University of Chicago, Johns Hopkins. And in the end, one of their external advisors, who actually is at Johns Hopkins, said, you know, the place you really need to go to is VCU, because they've put together really the strongest clinical resuscitation program really in the United States. And what really would be incredible would be if you could marry the basic science laboratory of the Weil Institute with the clinical programs at VCU. Over the next couple of months, they sent their chairman of the board and several of the staff, physician staff, to come visit. And to make a long story short, there was a unanimous vote, unquestioned vote, that they wanted to come to VCU, and they're now part of us. So we're really very proud of that fact, and we'll be probably having a public announcement and, you know, a grand opening in a few months once everything is settled. 2 trailer loads full of equipment arrived. So they're in the process of setting everything up.
Joe proudly sent me an image from the first experiment performed by the Weil Institute staff at VCU. Yeah. So they are up and running, absolutely up and running. And this is a great coup for us, as well as our other colleagues who are invested in critical care research, including the Victoria Johnson Center, which is a partner with the Weil Institute. So what you're seeing in Richmond is really the epicenter of critical care research, translational science, clinical care, and global outreach, which is really truly remarkable, truly remarkable. So I get my chance to ask my zingers here that were unprepared. I mentioned that injury prevention, trauma education is something that's terribly important. So I'm going to ask each of my colleagues here to give you one pearl about how to prevent a critical care injury or trauma. And I'll start with you, Michael.
It depends on the injury. One of the highest level of injuries that we're seeing now is a significant amount of falls injury. That's a major part. And a lot of the prevention really begins at home. and being able to, and there are a lot of programs that we have, the ability to go to your homes and look up and see how to, small things they can improve. It makes a big difference with regard to restructuring your home, prevent a lot of the injuries. And people underestimate when you get 55 years and older, your ability to recover from injury is very difficult. And even a ground level fall, something basic, has significant impact. So I think something is extremely important, and is take 5 minutes, and stop and take a look and say, what can we do? Little things at home that will change, whether the type of shoes you wear, the mattress you have in front of the door, the steps you take, all these things as far as modification of the home. This is probably one of the highest things that we see.
Michael.
I think one of the most common burn injuries we see is grease fires. And we have a grease prevention program called Put a Lid on It, Richmond. Actually, I did come up with that, but anyway. And the premise is you don't want to put water on grease. It'll explode. You don't want to grab the pan and run. It'll slosh on your hand. It catches on fire. Take it off the burner, put a lid on it, and you'll be so much better. You may even get to avoid me.
Mine's simple. Don't text.
I have, can I do two? I have two.
That's two's all right.
Okay. So one's really easy, wear your seatbelt. 90% of what we see is not gunshot wounds, it's car crashes and falls. And a lot of our folks who come in after car crashes haven't been wearing their seatbelts. And that's an easy way to keep you safe. The cars are designed to keep you safe. So that's one thing. The second thing is closer to my heart, because it has to do with some of my research, is keep a list of your medications on you. And that's because we actually don't have a great way of figuring out what medications you take. Primary care doctors aren't always available, aside from during the day, or pharmacists we have to call and chase down. We don't know what blood thinners people might be taking. Or one of the research projects that Dean Strauss is mentoring me on is trying to develop a blood test that allows us to detect what medications people are on when you come into the ER. First vial of blood, instead of getting a level of your hemoglobin, it's getting a list of your medications, because then we know if we need to give you something to reverse that blood thinner that you may be on. So a list of medications would be really easy thing to do.
Mine is because I'm a paranoid person with emergency management. See something, say something. No one is immune to bad things happening. If you see something, it looks unusual. We're not immune to a Boston here in Williamsburg or in Richmond. Make sure that you say something, tell someone that something looks different. Don't be afraid. And in addition to that, our big push, and from Washington, D.C., is stop the bleed. Remember, if we stop the bleeding from these injuries, that will probably save their life.
Yeah. Mine's a two-parter as well. The first part is what we call a risk assessment, and that basically means that we are all unique individuals with unique lives. And what's important is really trying to pre-plan, as we say, and really try to be realistic as to what are the kinds of things that you or your family or friends do that might impose risk. We've had some discussion about it. The second part is have a plan. 911, as we saw a moment ago, is very important as an early step, but also, to do the kinds of things that you're doing, which is to inform yourselves as much as possible about medical issues and emergencies. And if you can learn certain emergency procedures, first aid, and just hands-only CPR, those are the kinds of things that won't prevent an event from occurring, but can, as sadly we had to take a few actions, fortunately, very short-lived emergency, but having the ability to know exactly what your plan is going to be, so that when something unfolds, you're acting based on something that you've thought out in advance, rather than simply being a deer in the headlights.
Ryan, Margaret Ann, do we have time for some questions, or do you want to progress to the strolling supper? And
I think maybe we adjourn to the strolling supper.
okay, I don't want to deprive you of the opportunity to interact with our distinguished panel, but through questions. But I think that it would be good that we get some sustenance, and they will be there, and they have brought some important things, including ways to stop the bleed, to show you. Dr. Feldman has brought a variety of toys along with him as well to show you about the science of skin care and burn patients. And we thank you for your attention and always your engagement, and the pleasure of being with you this evening.